lonely life. I've been sleeping here instead. I've been sleeping in my bed. Sleeping in my bed. So show me family, all the blood that I would bleed. I don't know where I belong. I don't know where I went wrong. I can write a song. I belong with you, you belong with me in my sweetheart. I belong with you, you belong with me in my sweetheart. I don't think you're right for him. Look what it might have been. Took a bus to Chinatown. I'd be standing on Canal and Bowery. She'd be standing next to me. I belong with you, you belong with me in my sweetheart. I belong with you, you belong with me in my sweetheart. Love, we need it now. Let's focus on love. We're bleeding now. I belong with you, you belong with me in my sweetheart. I belong with you, you belong with me in my sweetheart. Give a little bit, give a little bit of your love. Give a little bit, give a little bit of my love to you. See the man with the lonely eyes. I'll take his hand, you'll be surprised. Give a little bit, give a little bit of my life for you. Give a little bit, give a little bit of your time to me. There's a time that we need to share. Some send a smile. We're on our way back home. Ooh, yeah. Yeah, yeah, you know Bernstein, Leonard, Brass, Snap, Lenny, Bush, and Lester Banks, birthday party, cheesecake, jelly bean, boom, symbiotic, patriotic, slam, button, nap, right? Right. It's the end of my life, it's the end of my life, it's the end of my It's the end of the world as we know it. It's the end of the world as we know it. It's the end of the world as we know it. I feel fine. It's the end of the world as we know it. It's the end of the world as we know it. It's the end of the world as we know it. I feel fine.
All right. Hello, everybody. Happy Friday. How are we doing today? Happy to see you guys. So, let's see. I'm kind of stalling, so I'm waiting for some more people to pop up. Weekly announcements. Week 6 assignment, you just have the ATI. That's available to you guys. I've seen a couple of you guys turn that in. Your exam grades will be posted after class at some point today. So that's all taken care of. You'll see those this afternoon. Let's see. Next big assignment you have is your presentation, your culture presentation. So, you know, be creative, have fun with it. I think it's more enjoyable to grade the voiceovers or the presentations than it is to read a paper, but that's just me. I like seeing how you guys teach and talk, and I'm not obviously saying that one thing is more easily graded than the other, but yeah, they're both the same, but I think it's more enjoyable. So that being said, if you are choosing like a Native American tribe, awesome. If you want to do something that is not on that list, that is not something you would see like in your textbooks or anything like that, you know, shoot me a message and we can discuss. But we really want you to expand away from the big ones that you would see in communities. You know, we're trying to expose you to more is the whole goal. So yeah, what else? Okay, next week you will have a sub. I have to go to Indianapolis, so there'll be another instructor with you. So don't be surprised when you see somebody else's face pop up instead of mine. I'm still going to try to hold office hours for those that need to meet kind of sporadically, but I am going to be out of town. So if you do need to meet, please message me and let me know, and we can try to arrange some things, but it might be some weird times. So I'll be East Coast time next week. So I'm going to try my darndest to keep it mountain time for you guys, but although like if 7 o'clock your time is like 9 o'clock out there. So I don't know how well that'll work. I'll try. I'm a night owl, so we'll make it work. But also if you see weird things popping up at like 5 in the morning, I'm not an early riser. It's just because of the time zones. Any questions? I am still going to host a review for the next exam next week. I think it's going to be Monday or Tuesday. I have to look at my calendar to see which day it's going to be, but it's going to be Monday or Tuesday. I think I'm leaning towards Monday, but again, I have to look at my calendar. And the same thing will go on where it'll get posted. It'll be in the YouTube, and you can go back if you can't attend. Also, if you need assistance with anything that was covered in the reviews for EKGs, let me know, and we can arrange some things to kind of solidify and button up topics. But you guys did a really good job on your chart in terms of, you know, filling it all in and having accurate information. So the plus side to me having to not be here last week was you didn't have to present it, because that's what the other groups had to do. They had to talk, so you didn't have to. All right. Any other questions? Concerns? We're good to go? Okay. Let's get this going because it's Friday. Anybody else feel like Friday? You just want it to hurry up and be done. Not that I don't love you guys. I don't know. All righty. Load this up here and we will rock and roll. So good news is that this is the final week of the cardiac system. So either you are really excited about this or you're like, oh, I really like the heart. I don't want to move on. So we've reached the end. So probably more good news than bad news. So this week we're going to go over peripheral vascular disorders, strokes, and hypertension. So caveat, and I'll bring this up again, we talk about strokes more from a cardiovascular standpoint than we do a neurological standpoint. So you're still going to get strokes next semester with neurological findings and things like that. But we're looking at how the heart causes strokes, what we would see, and then safety concerns, because regardless, if we have to worry about safety with our strokes. So, and then hopefully hypertension is just like, yes, I got this because we've been dealing with this since the very first day of nursing school. I don't know. So without further ado, one thing that has not gone away is knowing the blood frontwards and backwards through the heart. The amount of blood that your body requires is going to constantly change. This is based off of your tissue metabolism and how much oxygen is available and what the tissues actually do as a function. So when the metabolic needs increase, your vessels are going to dilate, which will increase oxygen and nutrients to the tissues. So when we work out, our tissues need more oxygen. Those vessels are going to dilate to help promote and give more blood flow. When we don't need as much, vasoconstriction is going to occur. So the amount of blood that your body is going to need is going to kind of ebb and flow based off of what is going on within your body. And then adequate blood flow is going to depend on how well your heart is pumping, the function. So how well is your heart pumping? How patent are your vessels? Do they dilate? And is the appropriate blood volume there? Or do we have something like decreased cardiac output? So just a little review here for you guys. One thing that's kind of interesting is that pretty much every system has what we consider occlusive diseases. So if we think about what occlusive means, it means that something can't get through. It's blocked or an impulse can't get through. So no matter what system we have a disease that goes along with this. Cardiovascular wise, angina. Angina has decreased blood flow. We have chest pain because the body needs oxygen, and that's why that pain is there. Stroke, we can have clots that form strokes. Blood can't get through. Can happen, clots can happen anywhere. Things like ulcers and gangrene, little teeny tiny clots form within the skin system. So we have occlusive isn't just clots, but also constriction of vessels and things along those lines. So the first thing that we're going to dive into are what we consider our peripheral vascular diseases. And we break those up into arterial and venous. So we're going to look at the artery ones first, and then we'll go into the venous. Both have similar things, but they're very, very different in the way that they present. So the first one that we dive into is peripheral artery disease. And the easiest way to think about peripheral artery disease is to think about coronary artery disease. So what happens with coronary artery disease? What happens to those coronary vessels?
They get backed up, like clogged up or like whatever, like plaque build up.
Yeah.
Yes.
Fatty lipids and gunk fills up those coronary arteries. Blood flow can't get through. It can result in an MI. Peripheral artery disease is the exact same thing, except it's our arteries in our periphery. So we usually see it in the legs. It could theoretically happen to your arms, but most commonly your legs. So arteriosclerosis is hardening and thickening of the arteries. This is the most common disease of the arteries. Atherosclerosis, I have such a hard time saying that, is the buildup of lipids and calcium and gook and carbs that create the plaques. These two terms are usually interchanged because one rarely occurs without the other. So we're not going to have a buildup of plaques without the hardening of the vessels. So again, arteries collect junk wherever they are, not just in the coronary vessels that we always think about. So the good news is those modifiable risk factors for coronary artery disease are also the same for peripheral artery disease. So what were our modifiable risk factors for coronary artery disease?
Smoking, obesity, diet,
Smoking, obesity, diet,
activity level,
100%.
hypertension,
Yep. Yep. So,
diabetes.
yep. One of probably the most important thing that we can modify is smoking. And it's not just because it's bad for you. It's because nicotine in tobacco decreases blood flow to your extremities, and it increases your blood pressure and heart rate. So if our arteries, especially like the peripheral ones, are having a hard time getting blood through already, constricting them even more is going to cause more issues. So we really want people to stop smoking. We have our non-modifiable, the things we can't change. With peripheral artery disease, again, it's the same. Genetic predisposition, age. The older you are, the more likely you are to have this, but also being female. Being female, biologically female, is a risk factor for peripheral artery disease. So the way that this is diagnosed most commonly is going to be an MRA, which is like an MRI, but it's looking at the blood vessels, not just tissues. So they use angiography to take a look at blood flow and see what's going on with obstructions and whatnot. There's also a test called an ankle brachial index, where they're going to take the blood pressure on your arm and then one on your ankle and compare it. They have to use a Doppler for this. Have any of you guys taken a blood pressure that was not around your bicep, not a brachial one? Sierra, how did that go?
I've mostly done it on babies, but it's harder because like it worried me the first time because it's higher the lower you go, And so it freaked me out the first time I did it because I was like, that number does not look good.
And it's not the easiest thing to take either. There's a high risk of it being inaccurate, which is why we do use a Doppler to assist with this. But basically, this ankle brachial index, again, we'll compare it. If it's over 0.9, we don't have peripheral artery disease. If it's less, we do. This is not commonly used in real world practice anymore because it's not overly accurate. But this is one of those tests that NCLEX and ATI loves. So will you actually use this? Probably not, but you'll see this test probably moving forward because why not? So we won't test you on it aside from like this could be used to diagnose peripheral artery disease, but that's about it. There's much better testing that we have for this. So looking at the assessment for peripheral artery disease, again, smoking is the #1 problem because of the vasoconstriction. Those risk factors, again, those cardiovascular risk factors that we talked about, that doesn't change. The expected findings are what are interesting here. So the hallmark sign of peripheral artery disease is intermittent claudication. Basically what happens is they're going to start walking or exercising and they're going to get pain in their butt. And when they stop walking, it goes away. So intermittent claudication with PAD is like angina of the butt. So we can have intermittent claudication with any body part, but with peripheral artery disease, it's going to be like in your hip and butt cheek pain. And it'll go away when we stop exercising, just like stable angina does with the chest. So there'll be some aching, cramping, or weakness with that activity. They stop it and they're good. Pain for patients with peripheral artery disease goes away when their feet are in the dependent position. So with peripheral artery disease, the arteries, which take blood from the heart and push it out everywhere, if our arteries are clogged in our legs, blood flow isn't getting to our feet. If our feet are in a dependent position, so like flat on the floor right now, it's forcing the blood down because of gravity, right? So arteries are going to get pushed down. If the legs are actually elevated, they have to work against gravity. It's not going to get there. So peripheral artery disease, we need it in a dependent position. So this is what feels best for them. And it's not uncommon for these patients to actually sleep with their legs dangling, like off the edge of the bed, because it's forcing the blood flow down to their feet. Also with PAD, we're going to have an increased capillary refill time, which makes sense because we have decreased blood flow. And we'll also have decreased pulses. Often with peripheral artery disease, there is no leg hair. It's not because they went to the salon and got a wax, it's because we don't have good blood flow, so hair isn't going to grow as often. So it's not uncommon to have hairless extremities with peripheral artery disease either. With foot positioning, when your foot is elevated, like above the heart, it'll be cool and pale. When it's in a dependent position, it's going to become reddened. It'll have that rubor. This looks like it's really painful, but it's not. It actually feels better for them. The nails typically become thickened and kind of opaque looking, and the skin is more shining. It is important to assess those peripheral pulses with arterial occlusive disorders. Unequal pulses between like feet or absence of them is a sign of peripheral artery disease. So we want to make sure that we gotta touch the feet. So again, feet in a dependent position, not elevated. We don't want their feet elevated. Questions on that stuff so far? Let's kick it off with a polling question then. So intermittent claudication is described as exercising that causes pain in the lower limb and is relieved with rest. Pallor with elevation and rubor in the dependent position are normal findings, but there's not a name for that. Intermittent claudication is that pain that happens with exercise. Alrighty, so what are we going to do about it? One of the big things that we have to do is we need to exercise. We need to get the blood pumping. So we're going to start low and increase gradually. Walking programs are one of the biggest interventions for peripheral artery disease. We want patients to walk to the point of pain, not chest pain, but walk to the point of pain, rest, and then they're going to start walking again and walk even further. So we want to find ways to increase movement. Silver sneakers, mall walkers. You guys remember mall walkers? I feel like they went away with COVID, but they get up and they'd walk the path of the mall in the morning at like 8 a.m. and before the mall even opened. But we really need to increase exercise gradually. We want them to keep moving. Additionally, we need to promote vasodilation. They like it warm. Have you ever walked into a patient's room and it was so hot you could barely breathe? They may have peripheral artery disease. Warmth increases vasodilation. So we want that. That's why they like it warm. It makes them feel better vascularly wise. We don't want to put direct heat onto patients' skin, however. Why do you think we don't want to do that?
Probably sensitive.
Decreased sensation, so they're not going to feel the heat as well, and it puts them at high risk for burns and injury. So warm compresses, sure. Fuzzy socks, absolutely. Extra blankets, whatever we can do, but heating pads on those extremities can be very, very dangerous. We also want to avoid vasoconstrictors as much as possible, reducing stress, reducing caffeine. As we mentioned, the positioning is going to be important. So no crossing of the legs. By crossing the legs, we're putting more pressure on that popliteal artery, which can decrease blood flow. It's kind of like when you have a garden hose and you kind of pinch it off, you don't get as much water out, it slows down. It's along those same lines. So keeping legs uncrossed. No restricting clothing, not raising the legs, we want them down. And medications, thankfully, guys, statins and antiplatelets, just like our coronary artery disease meds, same things. And not smoking. So there are also some therapeutic procedures that can be done. Percutaneous transluminal angioplasty. Does that sound familiar? The same thing we do for the coronary arteries, we can do these in the legs too. So same rules apply. Monitor for bleeding. We're going to give anticoagulants, antiplatelets. They're going to thread that catheter up, smush the plaques out of the way, put in a stent. Or maybe not put in a stent, it depends. They can or they can't. We also have the mechanical rotational abrasive arthrectomy. That's like rotor-rooting the artery, pulling gook out, scraping it clean. removing that kind of stuff. Same rules apply, bleeding, anticoagulants, that sort of thing. Surgery may also be an option for severe and disabling cases of this, basically the ones that are at risk for amputation because of tissue necrosis. So they can do a type of bypass or an endarterectomy where they go into the artery and remove the obstruction. But those are for significant cases where they're going to lose the limb because of bad blood flow and tissue death. What position should legs be in with peripheral artery disease?
Dependent.
Dependent. So feet on the floor. All right. Any other questions about PAD? All right. The next arterial disorder we're going to go through is Raynaud's. Raynaud's is actually a really common disorder. It would not surprise me if at least one of you guys in your cohort actually has this. And it basically is vasoconstriction in the hands and or feet. This is a genetic condition that is usually triggered by either stress or changes in temperature. So every so often the blood doesn't come through the artery closes off, so the blood won't get through. And then we have these what look like really white fingers. So another name for this is red, white, and blue disease. The white discoloration comes first, then the blue color when they become overly constricted, and then red as it opens up and redilates. For the most part, we diagnose this just by looking at it. It has those characteristics where you can see where maybe it's just like two fingers are completely white. It's kind of like a self-limiting disease in that sense. They can do a cold stimulation test where they'll expose the digits to extreme temperatures and also see if that can happen. In terms of interventions, it's really about avoiding triggers and promoting warmth. They can give calcium channel blockers to reduce the stress load of the heart. But this is if it's causing problems with like our ADLs. For most people, this is a completely livable disorder. But if it's interfering with them taking care of themselves, then calcium channel blockers are an option. So that's like your nifedipine or your amlodipine. Gloves, they might help. That truly depends on the person, but places like Utah and Wisconsin probably are not the greatest locations for people with Raynaud's because it gets so cold. They like a warmer environment to reduce the likelihood of it happening, and also avoiding stress. With darker skin tones, the darker the skin, it can turn gray or turn gray when it's pale. So they go kind of like a grayish white. With like a tan skin, it's going to go kind of yellow or green. And what's interesting about Raynaud's is that it's the same fingers that have the problems. It will always be the same fingers that are going to present themselves with the constriction. All right, easy enough. The next arterial disease is Buerger's disease, and this is a genetic condition that affects men who smoke. It can happen to women too, but it's more likely to happen to men. So basically what happens is it's just this chronic inflammation of your fingers and toes that causes little teeny tiny clots to form, which then will lead to ulcers and then gangrene, and then we have to cut off the fingers and toes. So men aged 20 to 35 are at highest risk for this, especially if they smoke. There'll be a lot of pain, very sensitive to cold. The number one intervention is to stop smoking. Everyone diagnosed has smoked or is currently smoking. And we don't usually say always, very often with medical stuff, but that is the contributing factor. No cold temperatures, somewhere warm, not. We want to increase blood flow, so no constrictive clothing. And then treatment, amputations, anti-inflammatories, because it's an inflammatory process, that sort of thing. It looks a lot like frostbite, in my opinion, where everything kind of clots off and ulcerates and then dies. So another reason not to smoke. All right. And then a few more pictures, because we love pictures. I want to throw these in for you guys. Arterial ulcers. These are caused by poor perfusion. We don't have good blood flow to the lower extremities. That skin, the top layer, is deprived of oxygen, which kills the tissue. And then the lack of blood flow can cause minor scrapes or cuts to not heal properly, leading to ulcers. So the arteries carry nutrient and oxygen-rich blood to all the tissues in the body. And with arterial ulcers, the blood flow isn't getting there, so something small can spread. And then that reduced blood flow leads to either the tissue necrosis and or these ulcers from forming. These arterial ulcers are usually located on toes or pressure points. So like the side of your foot or the balls of your feet. They're pale and kind of cyanotic because there's not good blood flow, and they're painful at night. So anybody who has impaired circulation, like peripheral artery disease, is at high risk for developing these arterial ulcers. So we want to treat arterial ulcers by taking care of the wound, protecting it, removing exudate, and increasing blood flow to the area. The greatest way to increase blood flow is going to be positioning. We want the blood to get forced down there. And again, protecting the wound. All right. Any questions about any of the arterial disorders? Pretty straightforward. All right, let's talk about the venous. The venous, I feel like, is even easier because we're going to talk about clots and insufficiency in varicose veins and venous ulcers. So venous thromboembolism is a VTE. That means it is a clot on the run. So when a clot is like in our leg, we call that a deep vein thrombosis. It's a DVT. A VTE is when it starts moving, and a PE is when it lands in the lungs. So a DVT becomes a VTE, which can become a PE. A lot of letters. So what causes clots to happen? Pooling of blood, which is the venous stasis, an injury, because that triggers the inflammatory response, which causes the clots to form, and then that hypercoagulability. Those three things together are called Virchow's triad. So an injury occurred, blood pooled, clots are formed. Also, there are things like genetic conditions, like factor V Leiden, which basically is a genetic condition that makes them clot happy. The clots are going to form by no fault of their own, but they would be at risk for clots to form like a VTE as well. Risk factors, we know risk factors for clots. Surgery, we create an inflammatory response, your body's healing, it's going to send platelets and everything to heal, right? Immobility, pregnancy, OCPs are a high risk for blood clots, active cancers. So we want to prevent them from happening. So how do we keep them moving? What other things do we do? And then when we have a DVT, can we recognize it? Limb pain is a very common symptom. Edema and redness are red flags, and we'll also see an increase in the limb circumference. So we'll measure with a tape measure, and we always measure bilaterally to make sure it's the same. So with clots, we have the D-dimer. The D-dimer is a lab that we can test for clots. It tells us that a clot exists, but it can't tell us where it is. So it's helpful in a sense, but it's just a piece of the puzzle because we need to do further investigation to figure out where does this clot live? In terms of medications, anticoagulants are our gold standard for treating DVTs. So subcutaneous heparin is used to prevent a DVT, okay? It's not used to treat them, it's used to prevent. So you've probably given some Q heparin in clinical, or your patients have been on it because they're not overly mobile. That's to prevent the clot from happening. If a clot's present, we can do IV heparin. If we do IV heparin, we have to know about our PTT, okay? We also have to be on the lookout for hypercoagulability, you know, all the thrombocytopenia, too many blood cells, the bleeding risks. And remember that protamine sulfate is the antidote for IV heparin. Lovenox subcutaneously can be used to both prevent and treat clots. We love this for overweight patients because it's weight-based. Sub-Q heparin is not. It's one dose, that's it. For larger body masses, it's not the best. Enoxaparin would be what we would want because, again, it's weight-based. Warfarin, 3 to 4 days to work. Vitamin K is the antidote. We have to be careful of our daily vitamin K intake, the same each day. It is not uncommon for patients to be on multiple anticoagulants while they're waiting for one to get therapeutic, because that way they're coagulated the entire time. Additionally, it is possible that patients could get TPA for clots depending on what caused them. If they had recent surgery, they are not a candidate because they just had surgery, they're high risk for bleeding. But if it's a DVT that pops normally, maybe they could. It truly is a benefit versus risk type thing, but it does exist. No matter what, we need to monitor for bleeding. So what does bleeding look for? Be comfortable with recognizing it. Bleeding gums, IV coming out, blood coming out of your IV, bruising really, really easily, that sort of thing. All right. Varicose veins, which are like the bane of women's existence. This is something we get to look forward to. Can it happen to men? Yeah, but it usually happens to women. Aren't we lucky? So varicose veins are basically enlarged superficial veins. They get all twisty and pathy. This is a very good example of some bigger ones. If you bang one of these on something or cut it open, it's kind of messy. They're right below the skin's surface. Varicose veins, they'll get a lot of muscle cramping and aches because of the blood and itching. So those are common symptoms with this. Our risk factors are obesity, family history, having a baby. Great. Thanks, kids. Being over 30 and positions where you sit or stand for long periods of time. So teachers and nurses are at high risk for developing varicose veins. Nocturnal cramps are very common. And then for treatment, the patient should avoid activities that cause venous stasis. So socks that are too tight, not compression stockings, just like actual socks that are too tight or clothes. We want them to move around, walk 30 minutes every day if there's no contraindications. Graduated compression stockings are very helpful with these. And then they can do types of surgeries for varicose veins where they'll do like ligating or stripping of the veins to remove them. The deeper, the bigger the vein, typically the more painful it is, but they can do a lot in these outpatient centers for varicose veins. Any questions on those?
Can spider veins lead to varicose veins?
I feel like they're their own separate thing because I know they can zap the spider veins with like a laser, and they look like just like the little red things, whereas the varicose veins are more like that blue tint that you would see. And they usually kind of bulge out a little bit, the real big ones. Awesome. So venous insufficiency. So this happens because blood can't get back to the heart. So arteries take blood and dump it out to the rest of the body. Veins take it back to the heart to go get recycled. Okay. With venous insufficiency, the valves inside the veins don't work well, and there's not enough force to get the blood back to the heart, which will result in pooling in the ankles and feet. The veins get bigger, which will cause this venous insufficiency. So typically we'll see a swollen ankle or foot first, and then there'll be what's called stasis dermatitis. So it kind of turns a little pigmented, gets a little darker skinned, maybe even a little thicker. There's a chart on page 845 that compares arterial and venous ulcers. You need to know the difference between the two. Also with venous insufficiency, it will lead to venous stasis ulcers, shallow on the medial malleoli. So out on that outer bone, you know, that one that we always hit on our bed frame when we're walking, you know, that's like the most uncomfortable bone. Very common for them to occur there. And then some cellulitis. So venous stasis ulcers, the treatment is different than arterial. Compression is key for venous stasis ulcers. Arterial is not. Moist wound healing and controlling the exudate is also important here. But what happens is that skin and redness starts to form on that subcutaneous tissue, and then it'll start to leak, and then we have some dead skin, and then it'll start to ulcerate. So we want to prevent that from happening. It's all because there's just too much blood in that area. Blood is caustic and can be damaging, and boom, we have some pretty ulcers. The teacher who taught this course with me last semester was a wound nurse. She loved extra pictures just to kind of put it into place. So these are some other examples of venous stasis ulcers. They take on average 24 weeks to heal, and 15% of these will never heal. And then it is estimated that up to $5 billion a year is spent on treating venous ulcers. Not any other kind, just venous ulcers. So again, compression therapy is the standard, but they'll need to be evaluated by wound therapy to determine if there's arterial involvement, because then they can change the pathway of how they're going to treat it. There's also something on page 874 that you should take a look at too with venous and arterial ulcers. So with venous ulcers, we want to elevate the legs because that decreases edema. It promotes venous return and helps with relief. Ambulation is also important and prolonged sitting isn't so good. We want to avoid putting pressure on the back of the knees, and extremities with venous insufficiency need to be protective to keep the skin clean, dry, and soft. So arterial, we want our feet in a dependent position, but venous, we want them elevated. Venous artery, we want, if they're ulcers, we want to protect and promote healing. Venous, we need compression. So there's some key differences. As I mentioned, in terms of diagnostics, D-dimer tells us that there's a clot. It's a marker. Yep, I'm here. Woohoo. The venous ultrasound is what we use to diagnose DVTs. And when they do that, they're going to do both legs because they want to compare the structures within both and be able to compare and contrast what's going on. So, teaching for our venous patients. DVTs, we need to put on compression stockings. How do you put on compression stockings?
Oh wait, like the SCD ones or like the ones that you roll up from the bottom?
Yeah, those.
That you go like this. I learned that in my CNA class because It actually is a lot harder than you realize.
Mhm.
I was like, oh, I got this. I can pass this off in front of the class. Got up there and I was like, okay. It was it was rough.
It's a struggle. You have to
Yeah.
like get it in like one fell swoop, no wrinkles. You want to pull them up as high as they're supposed to go. We have to measure, make sure they have the right size.
Mhm.
I've seen people use like the bag that they come in to like slide it up over to help with that. How I put them on, I delegate. That's not something I want to do. That sounds so bad, but it
I
is
thought you were
a
gonna say I don't. I just don't. I was like, perfect.
yeah. So, and what's tricky is no wrinkles. We want the skin dry. Yeah, not after a shower. If we put moisture underneath them, that's going to trap the moisture and can put them at risk for breakdown. You know, we usually put them on in the morning, take them off at night, not when we're bathing. And I don't know what's worse, putting them on or taking them off. Because, you know, when you take them off, you get the skin shower. So, yeah. Regardless, we want with DVT, we do want ambulation. So if we're concerned about a clot, we have them chill, don't move. We're not going to rub anything. We're not going to massage anything. I know it hurts, but stay put. Once they confirm the clot, they start treatment, then we're going to start with the ambulation. With venous insufficiency and varicose veins, compression is going to be key. With venous insufficiency, we want our legs elevated. Help the blood get back to the heart. That's why they're elevated. It can't do it on its own. We know how it'll just help it get back there easily. So when we say elevate, we really mean above the heart, which is kind of uncomfortable if you really think about it, because if you're laying flat, then you kind of got to have your legs pretty far up there. And with varicose veins, no sitting or standing for prolonged periods of time if we can prevent it. All right, and then the last thing, another visual for you guys. We go into wound vacs when we talk about wounds, but that is something that can be done to help with venous stasis ulcers, to help promote blood supplies. Blood supply and remove exudate. So the more wet a wound is, the longer it's going to take to heal. So a wound vac will continuously pull the icky gook out so it doesn't sit there and macerate the tissue and ruin the tissue. They can also go into hyperbaric chambers where they're going to get concentrated high amounts of oxygen to promote wound healing. IVC filters can be used with repeat clots. We talked about those with PEs. They're like that little cage thing that goes inside the vena cava that'll catch a clot so it doesn't get to the lungs. And then with varicose veins, lots of different treatments, vein stripping, removal, ligation. Sometimes it's like a one-day thing. Sometimes it may require multiple trips. Sorry, my cat just sneezed like 18 times in a row. It was really funny. All righty. A squirrel for sure. Okay. Read this carefully. Alrighty, so 3 types of venous diseases, and that's going to be your varicose veins, your VTE, and your venous insufficiency. PAD and Raynaud's are arterial disorders. And so is burgers. So that makes the other C and D incorrect because half of them are wrong. And then the first option aren't disorders at all, but actually tests and symptoms. So, oh, I didn't share, my bad. Alrighty then. Perfect time to take a break here before we dive into hypertension. So we are at 10:49. Let's come back at 11.
Can I ask a quick question?
Oh, sure.
On with venous insufficiency, would that cause like orthostatic hypotension? Like would patients be at a higher risk for falls because blood's not getting back up, or do you not really see that?
Not so much because the body will adjust and provide more blood, but we're just going to have the pooling because it can't get back to it. So the body will sense that like, oh, hey, I don't have quite enough, and it'll compensate for itself.
Okay.
But it'll definitely cause breakdown of the skin the longer that it pools and the more swelling that occurs.
Okay, that makes sense. Thanks.
Lately, I've been thinking, I want you to be happier. I want you to be happier. When the morning comes, when we see what we've become. In the cold light of day, we're a flame in the wind of the fire we've begun. Every argument, every word we can't take back. Cause with all that has happened, I think that we both know the way that the story ends. Then only for a minute I want to change my mind, 'cause this just don't feel right to me. I wanna raise your spirits, I want to see you smile. No, that means I'll have to leave. No, that means I'll have to leave. Lately, I've been thinking, I want you to be happier. I want you to be happier. When the evening falls, and I'm left there with my thoughts, and the image of you being with someone else, well, it's eating me up inside. But we ran our course, we pretended we're okay. Now if we jump together, at least we can swim far away from the wreck we made. Then only for a minute I want to change my mind, 'cause this just don't feel right to me. I wanna raise your spirits, I want to see you smile. No, that means I'll have to leave. No, that means I'll have to leave. Lately, I've been thinking, I want you to be happier. I want you to be happier. So I'll go. I will go. So I'll go. I will go. Lately, I've been thinking, I want you to be happier. I want you to be happier. Even though I might not like this, I think that you'll be happier. I want you to be happier. Then only for a minute I want to change my mind, 'cause this just don't feel right to me. I wanna raise your spirits, I want to see you smile. No, that means I'll have to leave. No, that means I'll have to leave. Lately, I've been thinking, I want you to be happier. I want you to be happier. So I'll go. I will go. You build me up and then I fall apart, 'cause I'm only human. I can turn it on. Be a good machine. I can hold the weight of worlds if that's what you need. Be your everything. I can do it. I can do it. I'll get through it. But I'm only human. And I think when I fall down, I'm only human. And I crash and I break down. Words in my head, lies in my heart. You build me up and then I fall apart, 'cause I'm only I'm only human. I'm only human. Just a little human. I can take so much till I've had enough. 'Cause I'm only human. And I bleed when I fall down. I'm only human. And I crash and I break down. Your words in my head, lies in my heart. You build me up and then I fall apart, 'cause I'm only keep on you have to face the word in your stare. I'm what's left, I'm what's right, I'm the enemy. I'm the hell that take you down, you to your knees. So who are you? Yeah, who are you?
Okie dokie. Let's bring it back here. And we're going to dive into our next portion, which goes over hypertension. There we go. Now I see faces. Now we're good. Okay. So hypertension is one of those things that you guys probably know a whole lot about already. So that is exciting. But we're going to review some of it anyway. So 2 types of hypertension, primary or secondary. Primary is also called essential hypertension. Most common reason for hypertension, we don't know why. It's idiopathic. Could be genetic, could be lifestyle. Truly, there could be a combination of things. So hypertension is a systolic blood pressure greater than 140 and or a diastolic of 90 based on 2 or more accurate blood pressures taken at least 1 to 4 weeks apart. The chart on page 885 explains the blood pressure classifications, normal, pre-hypertension, stage 1 and stage 2, you need to know. Additionally, about 1/3 of adults in the US have hypertension, and 45% of them don't even know that they have it. We see disparities with race and gender. For example, the prevalence of hypertension among African Americans is among the highest in the world, and they tend to develop hypertension at a younger age than white Americans. 95% of patients with high blood pressure, they will have no known cause for it. No, this is just my notes taken from your readings. Lost my train of thought. I can't multitask well today. Secondary hypertension occurs because of another reason, another disease. Kidney disease can cause hypertension. Pregnancy can cause hypertension. Another reason caused it. We call hypertension the silent killer because we are usually symptom-free with this. So to take you back, blood pressure is cardiac output times peripheral resistance. Will you ever figure that out in real life? No, but that's the formula for it. Cardiac output is the heart rate times stroke volume. So every time the heart contracts, pressure goes from the contraction of the heart muscle to the blood, and that pressure as it flows through the vessels is what we call the blood pressure. So, not gonna move. Here we go. Again, with primary or essential hypertension, that is the most common. That's the most common reason for hypertension. 95% of people with hypertension have essential hypertension, meaning it could be caused by lifestyle, genetics, or we just don't know. That secondary is going to be things like kidney disease or even medications. Stress can cause hypertension. Is hypertension reversible? most of the time it is with diet, exercise, and medications. So what do we see with hypertension? More often than not, we don't have symptoms. It's when they are asymptomatic for a long time, but they have high blood pressure. Because how often do we go to the doctor? Probably not as often as we should, right? Especially if we're healthy. If we have no reason to go, people tend to be like, oh yeah, I'm good, I don't need to go. They could be living with hypertension for years. And they'll have hypertension, but they don't know it. And then when we start to see symptoms, it's usually because we're starting to have damage from that years and years of high blood pressure. So if there are symptoms, it can be things like headache. Anytime we have a new onset of a headache, grab a blood pressure. Okay. Facial flushing, the face turns red. You can especially see it when you're pale like me. It turns bright red like the lady in the picture. The darker the skin, it just kind of gets like a darker pigment to it. So it can be harder to see. Dizziness, fainting, syncope, changes in vision are all things that we could potentially see with hypertension, especially long-term. Nosebleeds, nocturia, changes in urine, like having to get up to go to the bathroom in the middle of the night is a change in kidney function, which is usually a result of the hypertension. So to diagnose, again, you have to have more than 2 readings. If you take somebody's blood pressure once and it's high, that doesn't mean that they have it. It could be an instance. White coat syndrome is a very real condition. They'll go to their provider, they get so stressed out by being there that their blood pressure is super, super high. People get that when they go to the dentist because most people don't like going to the dentist and it freaks them out. And if they took their blood pressure, it'd be sky high, but they don't normally live that way. So that's why we have to do 2 or more readings within weeks apart. So again, pre-hypertension is going to be a systolic of 120 to 139 and a diastolic of 80 to 89. So it's below what we would diagnose as hypertension. It means that they're on their way. So we can do things like diet and exercise to kind of change things. Stage 1 is our first stage, greater than 140 up to 159, 90 to 99 diastolic. And then stage 2, greater than 160 and or a diastolic greater than 100. A blood pressure over 180 is dangerous. One thing that we have to keep into consideration too is the aging process. So somebody who's over 60, we don't diagnose as hypertensive until that systolic gets greater than 150. The kidneys don't work as well, so we have an expected, it takes longer for that diagnosis to kind of kick in. So if you or I were to go and we're under 60, because I think most of us are, if not everybody, a blood pressure of 148 over 88 would diagnose us multiple times as hypertensive, but somebody over 60, they're not there yet. So when they get older, the numbers increase a little bit. That's the moral of the story. So for the most part, we check blood pressures every visit, but if we are falling within that stage 1 range, so like 145 over 90, they're going to want to see you back in a month. They're going to check your blood pressure again. If it's still up there, then we're going to confirm that diagnosis. If it's over 180, they're going to treat your blood pressure right there. They're going to give you something to lower it and then see you back in a week to see if it's back up there, because then we need to treat you pretty aggressively. So hypertensive crisis is the big term. Hypertensive crisis consists of either a hypertensive emergency or hypertensive emergency. Either way, the crisis criteria is a systolic greater than 180 and or a diastolic greater than 120. So what causes a hypertensive crisis? An MI, a dissecting aortic aneurysm, brain bleed, a baby being pregnant. But we have to look at the two, urgency versus emergency, a little bit differently. So with hypertensive urgency, we need to lower the blood pressure because it's high, right? It's greater than 120 over 180 over 120, but we have a little bit of time because the other organs haven't been affected yet. So we're going to give oral meds, labetalol, captopril, clonidine, stuff to lower the blood pressure. With hypertensive emergency, yes, we have high blood pressure, but we also have organ damage, which is scary. We're starting to see changes, especially in our kidney function is usually the one that we see first because the kidneys are the martyrs and they take all the abuse. So emergency is worse. The blood pressure is high, but it's affecting our other organs. Urgency does not. So we want to decrease pretty quickly. So with emergency, we're going to give IV medications. And that's going to be things like nitro, cortisone drips, labetalol, that sort of thing. So urgency, we give oral meds. There is no organ damage, but we have high blood pressure. With emergency, high blood pressure, organ damage is starting to occur. We have to give IV meds. It's kind of like urgent care versus the emergency room. You get stung by a couple of bees, you might go to urgent care. You get stung, but you step on a hive and get stung by hundreds, you need to go to the emergency room. So both are considered crisis, but one is markedly worse because organ involvement has happened. Make sense? Okay. Let's do poll question here. I like seeing your guys' faces. All right, so how do we diagnose that blood pressure? We need that twice. So that answer was going to be C. We have to do it more than once. Once is an instance, so we have to have several times. Sorry, real quick. All right. So, how do we treat hypertensive? Meds, diet, exercise, and sometimes medications. Remember with asthma, when I said there isn't like a one size fits all approach, like it's trial, it's error. Some things work for some people need a lot, some people need a little. Same thing goes for blood pressure. So you could have somebody who is on 12.5 milligrams of hydrochlorothiazide once a day, and they are well controlled. Then you could have somebody who's on hydrochlorothiazide, a calcium channel blocker, a beta blocker, you name it. They're on a whole gamut. It truly depends. So we have to know certain things about every med. Diuretics. Thiazide and loop diuretics are potassium dumping, hypokalemia. So we need to encourage potassium-rich foods, keeping it up there. Probably may need to be supplemented. Spironolactone is a diuretic, but it's potassium sparing. So we run the risk of hyperkalemia. So we'd want to avoid potassium supplements, Mrs. Dash, all that kind of stuff. Calcium channel blockers, verapamil, amlodipine, ditalizem. I love those drugs. They're great. But no grapefruit juice. It causes a toxic interaction. So yeah, we know that it lowers blood pressure, but we can't do that. Always, 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 always get a blood pressure before you give a blood pressure med. I know it sounds like common sense, Amy, but you'd not believe. And when in doubt, double check. Like if you're like, oh, there was systolics 122, I'm afraid that if I give it to them, they might bottom out too much. It depends on the drug, depends on your patient and what's going on. But you'll see that your orders usually have parameters, but we have to have a recent blood pressure and heart rate. ACE inhibitors. We always teach you about that ACE cough. We want to make sure that they're not developing it. It can happen at any time. More so even, they have it with ARBs, but angioedema. We have to be on the lookout, especially with African Americans. Lisinopril can cause angioedema at any time. And it's one of the scariest things I've ever seen as a nurse, because the lips puff out real huge, the tongue gets real swollen, our airway is compromised. So definitely one of those things that we need to look out for with ACEs and ARBs. Beta blockers, we don't stop it suddenly because it can cause rebound hypertension. And if they are diabetic, it can cause low blood sugar. That's something we forget about a whole lot. And then our centra alpha 2 agonists, these are our clonidine. Clonidine is a little pill, small dose, like 0.1, sometimes 0.2 with our really bad ones, and it packs a punch. Really helps lower blood pressure, but it also takes away an erection. So there can be an issue with compliance with this medication. It takes a while to figure out what medication is best, but every group has its own side effects that we need to be on the lookout for. If we are giving medications, that is an intervention. We have to do teaching that goes along with it. So you make sure that you understand you may need more potassium or you may not need it. Let us know if you have a cough, no grapefruit juice, those standard teachings. All right, education. One of the big interventions we want people to do is to keep a heart journal. Record your blood pressure and your pulse. So we need to teach them how to use the machine. Are they doing it properly? Feet flat on the floor, that sort of thing. We want them to keep a journal because if we can lower the blood pressure, we can begin to taper. We don't want to keep people on meds forever, but if they can record and they can keep track and they're doing well with diet and exercise, the goal is for them not to be on them forever. So that's one way that we can have them keep track if they are consistently lower than 140. Also, our electrolyte imbalances, making sure that they're aware of what it feels like. What does hypokalemia look like? Are they comfortable with all that? Heart failure, our signs and symptoms of heart failure, holding on to fluid. Remember, right-sided heart failure, we're going to have edema. Left-sided heart failure, we're going to have more respiratory issues. All things that they need to be aware of. Lightheadedness and dizziness. Maybe our meds work too good and we lowered their blood pressure too much. So these are things that they need to be educated to look out for. Also compliance, following up with their providers, getting those blood pressures checked and adhering to their regimen. All very valuable information that patients need to be aware of. Giving information in language that they can understand. I mean, how many of you guys have looked at your Hinkle and Cheever book and been like, I have no idea what they're actually saying? And people can feel that way with the education handouts we give them. So are we communicating to them in a way that makes sense? So one of the things that can happen, I don't mean to giggle, I don't know why I laughed, is hypotension. We get those blood pressures a little bit too low, aka a systolic less than 90. We'll see a decrease in their level of consciousness. They may be a little bit more difficult to arouse. They're weak. They're tired. So hypotension can happen for a number of reasons. But again, if we're trying to lower blood pressure, we might do it too well. I always say it is easier to lower something than it is to bring it back up. Think about blood sugar. If we give you too much insulin and we bottom you out, it takes forever to get the blood sugar back to normal. Kind of like that with blood pressure. We have to work a little bit harder, and it's a little bit more dangerous if we have to raise things. So can you recognize that the blood pressure is too low symptom-wise? Weak, difficult to arouse, and then that low systolic. The way that we fix low blood pressure is to give fluids. We want to replace volume. So we'll give things like 0.9 NS or LR to help raise the pressure. If they're fluid overloaded, we still give it to an extent, but we have to be careful that we don't overload them. So it'll be like a gentle hydration. In really bad situations, or maybe with like a septic patient, super sick, we give vasopressors. So these are things like norepinephrine or dopamine that they get placed, that they get given to raise their blood pressure. And once they reach the mean arterial pressure or a certain systolic, then we'll turn it down and we'll continue to monitor, go back and forth and titrate it. These are intense drugs. They prefer a central line. Like usually they don't even give them unless we have some kind of central line, and are very one-to-one patients, or maybe 1-2 because they require a lot of frequent monitoring. So can you recognize what the low blood pressure looks like as well? All right, the big bad scary things that can happen because of high blood pressure. The number one complication of high blood pressure is kidney injury. Those poor kidneys. I think they're my favorite organ and they really take a beating. We will start to see the injury with their BUN and creatinine. So that will start to rise, concentrated urine, not as much coming out or more frequent, but the kidneys really take the beating. Remember your RAA pathway, the heart, hormones, cycling with pressures. So the kidneys really can take damage here. That hypertensive crisis can happen with uncontrolled hypertension, can cause long-term organ damage. And then we're going to talk about strokes in a little while. The number one cause of a hemorrhagic stroke is high blood pressure. Heart failure. If the heart is working, eventually it's going to kind of poop out and start to fail. So do we remember the test associated with heart failure? Your BNP is going to help us determine that. Hypertension can also cause peripheral artery disease and venous diseases because we have poor output, or it's working too hard. So that is a potential complication of high blood pressure. So it's not just, the core organs, it's throughout the whole body. And then left ventricular hypertrophy. That left ventricle is what pushes out the blood, right? It's the last step out the ventricle, out that valve to the rest of the body. If it's working so hard, it's going to atrophy and thicken over time, and we're going to see a decrease in cardiac output, even though it's still trying to push it out. And we can see that on an EKG. The R wave will be, the tip of the R wave will be really high, which means the ventricles are too big. Questions on hypertension? What kind of diet would you recommend for somebody with hypertension?
Low sodium.
2-gram sodium diet, right? That doesn't go away. It doesn't matter what's going on with the heart. 2 grams of sodium. Oakley dokley. Oh, a question for you. right, I should unmute. The most common complication in hypertension is going to be kidney injury. Okay, so next thing we're going to talk about are aneurysms. So I don't know about you, but when I think about aneurysms, I think about the brain. I feel like it's one of the most common things, like people get an aneurysm, they go see a neurosurgeon. Maybe it's because I watch Grey's Anatomy, Derek Shepherd, I don't know. But I always think about the brain with aneurysms. But an aneurysm really is just a weak point that causes a bulge in an artery. So it can happen anywhere. We can get arteries in our head, we can get it in our chest, we can get it in our legs, in our hands, anywhere. So with aneurysms, we basically have two kinds. We have what's called a fusiform aneurysm or a saccular aneurysm. A fusiform, we have weakening of the arterial wall, kind of on both sides. So it bulges out, kind of like a balloon. And then a saccular aneurysm happens on one side of the arterial wall, where kind of like a ball forms. Both will have extra blood present. Saccular aneurysms are at high risk for developing clots because it could just kind of hang out there, right? Blood comes in, it pools, very dangerous. But there are some risk factors. Guys, this one's your time to shine. Men are more likely to have aneurysms than women, which is surprising. Anybody with atherosclerosis, so we have hardening and thickening of the arteries, buildup of gunk, uncontrolled hypertension, smoking, high cholesterol, family history, age, blunt force trauma can cause an aneurysm, and syphilis. So syphilis, if it is not treated, okay? So it's one of those STIs, it's kind of resurging, especially with the older population, but we don't see it as much anymore, the syphilis causing aneurysms because, you know, penicillin. But if we treat syphilis quickly, we have less potential complications, like, you know, your brain turning to Swiss cheese and going crazy, or developing aneurysms. So it's there, but we don't see it as much anymore. So in terms of aneurysms, we talk about two kinds because we're talking about the heart. So we're diving into abdominal aortic aneurysms, our AAAs, and aortic dissections. There are many, many more types of aneurysms, but we're going to be talking about these two. So your AAA is your most common, and your aortic dissection is the most deadly. So with AAAs, basically the artery, the aorta, comes off of the top of the heart, right? The aorta is what supplies blood to the rest of the body, but that aorta goes all the way down into your abdomen, okay? And with a AAA, the walls get distended and weak, and it starts to bulge. So we see this most often in patients that have cholesterol issues, arterial, you know, high cholesterol, hyperlipidemia, atherosclerosis. Also, we see it in patients that have inflammatory disorders or connective tissue disorders. Ehlers-Danlos syndrome is a hyperplastic skin condition where skin and tissues can kind of be pulled away from the body. They would be at high risk for this. Or Marfan's. I call that the Abraham Lincoln disease. Really tall, really thin, long fingers, long arms and legs. Marfan's have a lot of cardiac issues, and we see AAAs happen very commonly with them. So with AAAs, we usually don't have symptoms, which is really, really scary. We can have some abdominal pain. There could also be some intermittent back pain. And then the one thing that we can see is a pulsating abdominal mass. Any of you ladies have babies? And you know when the baby moves, or maybe you've seen a baby move, you can kind of see like it moving on the stomach, like their leg drawn across or something like that. It kind of looks like an alien inside the belly. That's what the AAAs look like. You can literally see the heartbeat because it's pulsing, because arteries pulse. So their stomach will go like this, which it shouldn't do. So back pain, or like a ripping, tearing back pain, or a chest pain and high blood pressure, and then that pulsing abdominal mass could mean that a rupture is coming. And if it ruptures, then we have what we call a life-threatening emergency, massive hemorrhage. We need to replace fluid, and we need to replace it quickly, and we need to get them into surgery. So if it ruptures, simultaneous fluid resuscitation and getting them in for immediate repair. As I mentioned, clots can form with these types of aneurysms, so we want to make sure that we are assessing the 6 Ps: pain, pallor, pulselessness, paresthesia, paralysis, and poikiliothermia, to make sure that we're not having any issues distally. But some people will live with a AAA for years. Maybe they go in, I'm having stomach pain, or they come in with symptoms of appendicitis. They scan their belly and they find a tiny AAA. So it's like an incidental finding. If it's small enough, they'll continue to monitor it. You'll have repeat scans, you know, if it's not bothering you, but then if it starts to grow or then it reaches a certain point, then they'll be like, all right, let's do some surgery on this bad boy. That high blood pressure is definitely something that we will see with the AAA. One night I was working and a person came in, the pager went off in the ER, and it said it was like a 60-year-old woman, back pain. She was like 180 over 110. Okay, she's in pain, so it's not uncommon to have high blood pressures. And she comes in and EMS is giving me the rundown, and they pull back the blanket to like unload her onto my bed, and I could see her stomach going like this. And I said, she needs to get to the trauma room right now. So they don't even unload her. They take her back and they take her into trauma, and they come down and they take a look at her, and within 45 minutes, she went to surgery and she died afterwards because the rupture, it's a massive hemorrhage and it is very hard to control. So it is definitely something that we want to be on the lookout for and be prepared for. Just trying to find something really quick. All my browser tabs closed on me and I usually have them set up. Here we go. I found it. So that's what the pulsatile abdominal mass can look like. It kind of looks like an alien. You see the heartbeat, and then they'll open it up, and that should not be as big and wide as it is. So nice little visual aid for you guys. And then we have the aortic dissection. So this is the most deadly. When the aorta dissects, there is approximately a 20% survival rate, and that's being very, very generous. It starts with a tiny cut in the aorta. All right, so that here's your aortic wall, a little cut forms, and blood will start to flow down this, what they call a false lumen. More and more blood is going to enter this space, and people are going to die of blood loss because blood gets stuck in this area, and as it tears, it's going to occlude the artery. So it's the ripping of the endothelium inside that artery. They will have a tearing back pain, a pulseless arm, chest pain, like the worst it could possibly be. They go into hypovolemic shock, and they pass away. This happens very quickly. This is the reason why it's so deadly, is we can't catch it in time. So low blood pressure, high heart rate, poor pulses, people that are at risk for aortic dissections, hypertension, uncontrolled hypertension, and that Marfan syndrome. So this is a very deadly disease. And again, it happens really quick, just tearing from weakened arterial walls. All right, polling question. Oh, I'm so sorry, William. Is kind of some of the stuff that I mentioned, like similar to what happened. Okay. Does anybody watch Grey's Anatomy? This happened on an episode. The guy came in with like indigestion and chest pain, and they found out he had a dissection, and he like died right very, very quickly. Yeah, 54. Wow. Alrighty, so why is it so life-threatening? And that is going to be because it occludes blood flow from the aorta. It doesn't create a hypervolemia, it creates a hypo. It doesn't have anything to do with blood sugar. And it is always dangerous because it's basically tearing. The weakened wall has begun to tear. All right. Well, we went through that really quickly because people didn't have stuff to add. So I'm still going to take our break here because next we go into strokes, and that's a lot. So where are we at for time here? 11:38. 48. 11:50. Let's come on back.
Won't you come see about me? I'll be alone, dancing, you know it, baby. Tell me your troubles and doubts, giving everything inside and out. And love strange, so real in the dark. Think of the tender things that we were working on. Slow change may pull us apart. Wanna like get in your heart, baby. Don't you forget about me. Don't you forget about me. Will you stand above me? Look my way, never love me. Rain keeps falling down, down, down. Will you recognize me? Call my Don't leave me. Walk around, choose your own ground. How you live, how you fly. Stars will give and tears will cry. All you touch and all you see, all your life will ever be. Run, rabbit, run. Dig that hole, get the sun. When at last the work is done, round to down, it's time to dig another one. How you live, how you fly, only if you ride the tide. Balanced on the biggest wave, race towards another grave. You say you'll be down and fast. Smell of your perfume, it's floating down the stairs. You're fixing up your hair like you do. I know that I'll be a mess the second that I see you. You won't be surprised, it happens every time, it's nothing new. It's always on a night like tonight. I thank God you can read my mind. Just when you look at me with those eyes, I'm speechless, staring at you standing there in that dress. What it's doing to me ain't a secret, 'cause watching you is all that I can do. And I'm speechless, you already know that you're my weakness. After all this time I'm just as nervous every time you walk into the room. I'm speechless. Started when you said hello, just did something to me. And I've been in a daze ever since the day that we met. You took the breath out of my lungs, can't even fight it. And out of the words out of my mouth without even trying. And I'm speechless, staring at you standing there in that dress. What it's doing to me ain't a secret, 'cause watching you is all that I can do. And I'm speechless, you already know that you're my weakness. After all this time I'm just as nervous every time you walk into the room. I'm speechless. Yeah, baby. It's always on a night like tonight. I thank God you can read my mind. When you look at me with those eyes, I'm speechless, standing there in that dress. Girl, it ain't a secret, watching you is all that I can do. Oh, I'm speechless, you already know that you're my weakness. After all this time I'm just as nervous every time you walk into the room. I'm speechless. Oh, you know it. And I know she'll be the death of me, at least we'll both be numb. And she'll always get the best of me, the worst is yet to come. But at least we'll both be beautiful and stay forever young. This I know, this I know. She told me don't worry about it. She told me don't worry no more. We both know we can't go without it. She told me you'll never be alone. I can feel my face when I'm with you, but I love it, but I love it. Oh, I can feel my face when I'm with you, but I love it, but I love it. Oh, and I know she'll be the death of me, at least we'll both be numb. And she'll always get the best of me, the worst is yet to come. All the misery was necessary when we're deep in love. 'Cause I know, then I know. She told me don't worry about it. She told me don't worry no more. We both know we can't go without it. She told me you'll never be alone. I can feel my face when I'm with you, but I love it, but I love it.
All right. I always like to start this section with that song because that song makes me feel like they're having a stroke. So it kind of connects the dots for me. I don't know. The way my mind works. So somebody asked a question when they say statistically heart disease is the #1 killer. Are they referring to all of these different diseases? Yeah, because heart disease in and of itself, it could be high cholesterol, it could be hypertension. The more diseases, heart diseases you have, the more likely you are for something to go wrong. So it's a blanket statement for everything that could go wrong. Okay, so the next big chunk of stuff, stroke. So again, we cover more from a cardiovascular standpoint. COTAC 2 will go from a neurological, but it's all important to know. Safety is paramount here, preventing secondary injury. But from a patho point, we're going more cardiac side, if that makes sense. So, stroke symptoms. I'm not going to move. Just going to sit here, click, and it's not going to go. There we go. We have to be able to identify a stroke. Can we see it? I feel like as a nurse, strokes are the one thing that scares me the most. Because I'm always so afraid I'm going to miss something. Give me a bloody trauma. I got you. But strokes scare me because sometimes the symptoms are so innocuous or like slight. It's a fear of mine. Get over it, Amy. At any rate, you guys have probably seen this mnemonic in some way, shape, or form before. It is not uncommon to see these in elevators and hospitals. We want to spread awareness of what strokes look like. So be fast is the mnemonic that we use. B is our balance. Stroke can offset people's balance, make them woozy, give them a headache or dizziness. Eyes, blurred vision, difficulty seeing, not being able to see at all, some kind of visual disturbance. Face, the side of the face is drooping. I think that's probably the symptom we associate with stroke the most because we can see it. You know, it'll be kind of just off, tilted. Sometimes we might not see it. So we tell people, stick out your tongue. So when you stick your tongue out, it's midline. But somebody who's having facial drooping, it'll kind of go off to the side. It won't be midline anymore. So even if we can't see the drooping, the tongue, we can see the shift. Arms are another one. We can see difficulties with the arms or legs with weakness. So what we'll have them do, either squeeze 2 fingers, we can feel unequal grip strength, or if we have them stick their arms out like this, one could potentially fall. So we could see like a deficit of one side. Speech, can be difficulty finding words, not being able to speak at all, or it's very garbled. And then time. It is important that with ischemic strokes, we give TPA as soon as possible. So time is of the essence. We need to move quickly. Pardon me. Okay, stranger danger. So one of the questions that we have to ask is, when is the last known well time? This can be difficult because do you know when most people say their last known well time was? Before they went to bed. And then they wake up and they find them like this, and there's no way of knowing when it was. You know, if it happened an hour ago in their sleep or right when they fell asleep. So it can be difficult. So what do we see with stroke? Ooh. Oh, sorry, Alexandra. Hey, that's enough. So squirrel moment here. I was watching Ozark last night. I'm on like the last few episodes, and the dog started barking on the TV. And my dog like was dead sleep. All of a sudden he raised his head up and he's just looking, and then he's like watching the TV, like looking for the dog. I'm like, go back to bed. So I get it. All right. So back to the Be Fast real quick. These are the big symptoms we teach the public to watch for, but there are many different symptoms that could happen depending on where the stroke is located. Okay, so we look at things left and right brain. Okay, so if there's something that happens to the left side of the brain, we have certain findings that we'd see, but left-sided strokes will result in right-sided deficits, and right-sided strokes will have problems with your left side. But there are some things that we see characteristic-wise or things like that that are dictated by left and right. So with left-sided strokes, the language center is affected. So we would see issues with communication or logic. So aphasia means that a patient is unable to speak or unable to recall words, or they're jumbling, or they just can't remember it. Agnosia means that they're forgetting normal things, like they might not be able to recognize smells or other senses, or you could put a pen in their hand and they can't recall that it's a pen, even though they know what it is. Agraphia means that they can't write, and alexia means that they can't read. So even they could read before, but for whatever reason, now that this thing has happened on the left side of their brain, they're having issues with that. With left-sided strokes, there's a math deficit. Simple math skills tend to be lacking, and analytical thinking kind of goes out the window. What will happen if I hold a pen like this? It could drop, but they don't understand like the results of their actions. Hemiplegia, hemiparesis, and hemaniopsia can happen with either side. So hemiplegia is like a paralysis. So if it's a left-sided stroke, they can't move the right side of their body. Hemiparesis is weakness of that side. And then hemaniopsia means they can't see that part of, they might have impaired vision in here or on the outside. They can only have partial field of vision. Right-sided strokes cause left-sided symptoms. Physically, yes. So if the bleed is on the right side, their left side will be affected, but then they're going to have some of these other findings with right-sided brain or neural functions, if that kind of makes sense. So the brain has functions that the left side do and that the right side do, but physically their limitations would be on the opposite side. Left-sided strokes also, they tend to exhibit a lot of slow, cautious behavior. Then our right-sided changes, our creative ability, that tends to go away. Still that hemaniopsia. And then one of the big things that we see is our spatial awareness, your depth perception. Like I constantly feel like something is wrong with me. You walk in through a doorway, except you walk right into the doorway because you don't realize how close it is to you. So that's what we mean by depth perception. We can't figure out how far away something is. Spatial awareness, you can't find your nose on your face, that sort of thing. With proprioception, we can't figure out what our feet are doing. There's a disconnect. And then unilateral neglect. They're going to just ignore everything on one side. So even if it's not disturbed, like weakness or anything like that, they won't be able to, they'll just ignore it. If I put my coffee cup on my left side, I'm gonna not use my left hand, I'm gonna use my right hand. I just completely ignore or don't even connect that I could use that left side of my body. We can't teach them to just use it. We can encourage though, like, why don't we try the other hand? Try to remind them that they can use these things. Same thing with the field of vision. We can't teach them to see again. It would just happen on its own. Also, oh, sorry, my bad. We have a altered perception of deficits. If you've ever been around a 2-year-old, they think that they can do everything. I can put on my shoes. I can put on my pants. I can do this. I can do that. It's a lot like that. They think they are not aware of their deficits. They think that they can still do everything. They don't know that something is wrong. They tend to also be a lot more impulsive. So again, there are findings we see with the left and findings we see with the right, and sometimes we have some that will cross over. We gauge strokes on the NIH stroke scale, and we'll talk about more of that in a little bit. So in terms of the types of strokes that we have, we go over 3 kinds. Our TIAs, which are not technically a stroke, they're like a precursor to one. Ischemic strokes, which are our clots, and our hemorrhagic strokes. So with TIAs, these are when they're kind of like brain farts that will result in stroke-like symptoms, maybe some slurred speech, some weakness, some deficits, but they go away within an hour or 2. It will resolve. So it's a temporary loss of function. It's a warning sign that something bigger is coming. 15% of ischemic strokes had TIAs beforehand, which is a pretty big amount actually. But what happens is there's a temporary loss of oxygen to the brain, resulting in this going on. So one of the treatments for a TIA is to restore blood flow. So remember earlier today, I talked about how any artery can get full of gook and full of ickiness and get clogged up. Well, that can happen to your carotid artery. Your carotid artery is what supplies blood to the top of your head and into your brain. So if that carotid starts to get narrow, decreased blood flow is going to go to the brain, which can result in ischemia. So one of the things that they can do is an endarterectomy, where they go into the carotid and they pull some of that plaque out to restore blood flow to the brain and prevent future TIAs from happening. With ischemic strokes, this is when we have loss of function because of a clot. And one of the most common things that happens is that something breaks off, usually from the carotid, and it lodges itself in the brain. Because it's occlusive, blood flow can't get through and resulting in the tissue dying inside the brain. So with ischemic strokes, this makes up about 87% of strokes, and they'll usually present with some kind of numbness or weakness on one side of the body, a change in mental status, some confusion, trouble speaking, visual disturbances, all that BFAST stuff is going to be positive. Or also a severe headache. Table 76-2 is important to help you review frequently seen neurological deficits. I forget what page it's on, but it's 76-2. Knowing their last known well time is crucial. Initial diagnostics are usually a non-contrast CT performed urgently, and that's to determine if it's an ischemic stroke or a hemorrhagic stroke. They can also do things like a CT angio or an MRI based off of that first finding. Primary prevention of an ischemic stroke is the best approach to preventing this from happening. So no smoking, DASH diet, low dose aspirin, just overall being healthy as much as possible. Stroke screenings at yearly checkups, because we want to, preventative health care is important. And then modifiable risk factors like high cholesterol, excessive alcohol consumption, high blood pressure, obesity, sedentary lifestyle, and smoking, if I didn't say that already. The treatment for an ischemic stroke is TPA. They'll thread a catheter into the brain if it's before 6 hours. So with TPA, it's if it's not contraindicated. And some of these are more relative contraindications. It's going to be a risk versus benefits to determine if it's something that we need to do. But they can do this again, intra-arterial, so in through a line or through an IV. 6 hours is our window. After 6 hours, there's risks to getting the medication and no advantages because brain tissue has already begun to die. So we want to make sure that the symptoms are less than 6 hours, that their blood pressure is okay, they're not having seizures, bleeding precautions in place, no recent surgery. So that makes it difficult because sometimes ischemic strokes can happen from a blood clot dislodging. But more often than not, it's going to be something from arterial plaques and that sort of thing. Questions on ischemic strokes? Hemorrhagic strokes. This is bleeding into the brain tissue, the ventricles, or the subarachnoid space. These are the worst kind of strokes. This is 80% of hemorrhagic strokes are caused by hypertension. So it causes weakness of the vessels and can cause for them to rupture. Other causes are things like cancers, aneurysms, or AVMs, which are arteriovenous malformations, which we don't go into in this class. We look at it just as the hypertension causing this. Symptoms are similar to an ischemic stroke. The most common thing is a severe headache that came out of nowhere. A CT or an MRI is going to help determine the kind of stroke that it is. We can see a hemorrhagic stroke on a CT scan. We see the blood. Ischemic strokes, we actually don't see until there's tissue death. We don't see it for days later. But if there's bleeding in the brain, we're not giving contrast. The management of strokes is to allow the brain to recover from the initial bleed. So sedation or bed rest is very, very common. If the bleeding is caused by medications, they try to reverse that if they can, and potential surgery if they are stable. So hemorrhagic strokes, 80% are caused by hypertension. Other risk factors, cerebral aneurysms, those AVMs, diabetes, obesity, smoking, high cholesterol. Are we sensing a trend? Like it's the same thing over and over. Oral contraceptive use, smoking. It says cocaine, any type of stimulant drugs, because meth isn't on that list, but meth definitely increase your risk of stroke. Anything that's going to make the heart go into overdrive and put too much pressure, increasing blood pressure, is going to put you at risk for a stroke. I mentioned yearly screenings. This is an example of what a screening could look like, where they would check off where they fall in each of these categories, which is really interesting because you guys as nursing students, I'm sure quite a few of you are in the caution range for blood pressure because, you know, stress. You know, if you smoke, that can put it at risk, or, you know, I don't know about you, but I don't get to work out as much as I would like. So certain things like these, if you take a look at, especially as we get older, the higher risk we are. So these are the things that we kind of look for in terms of preventing strokes and what can we do to change and make things better. Whew. Let's do a poll. And this is the worst kind of select all that apply question ever because there are so many answers. So I'm going to give you guys a couple of minutes to read through them all. I would never give you guys this many options. I'm going to close my shades real quick to make my dog be quiet. I'll be right back. Okay, I'm going to give a little bit more time because I know there are so many options. Alrighty, so what statements are true about the expected findings of stroke? So a patient can be taught to see with a diagnosis of hemaniopsia. True or false? This is false. We can't teach them to see. They can be taught to care for their affected side with unilateral neglect. Yes, we can re-encourage and teach them and make them aware that the deficit is there. So 2 is true. 3, aphasia means the ability has lost the ability to speak. That is true. Agraphia means the ability to write, lost the ability to write. That is true. So 2, 3, and 4. A left cerebral stroke can lower a patient's inhibitions. That is false. A right cerebral stroke can lower a patient's inhibitions. So 6. A left can cause a patient to be more cautious. This is true. So the right would be false. And then BFAST stands for balance, eyes, face, arm, speech, and time. So 2, 3, 4, 6, 7, 9. Oakley dokley. So the NIH stroke scale is what it will be used to determine how severe the stroke is. Who does an NIH stroke scale? Or who needs to be, you have to get certified through the NIH. You take a course, it's a couple of hours. You could do it now, it's free. A lot of modules go into it. I don't recommend it because you guys don't have a whole lot of time, but it usually is part of your training. Nurses that need to be NIH stroke scale certified are those who would deal with stroke patients. ER, ICU, neuro, those are the big areas that I can think of off the top of my head. I don't know if PACU maybe too, or OR, but somebody like mom and baby or labor and delivery, you might see strokes, but you don't have to rate their severity is kind of where I'm going with this. So you may never do it depending on where you work, but it exists and that you do need to know. So with the stroke assessment, again, when were they last well? Any history of TIAs? We want to do a rapid physical and neurological exam. If we are, no matter what, ABCs, guys, with stroke, airway, breathing, circulation, and then everything else falls afterwards. We're looking for gross neurological deficits. Gross doesn't mean icky in this case. It means like severe, significant. They can't do anything neurologically, maybe on one side of their body or that sort of thing. Our goal with strokes is to minimize brain tissue damage, because the more tissue is damaged, the worse the stroke will be. So with the stroke scale, you don't have to have this memorized, but a 0 means they don't have any stroke symptoms, and it goes up to 42, which means they've had a severe stroke. They get based, there's different categories, different strengths, different words, things that they look for. It's pretty detailed. Maybe you'll see it in the documentation of patients' charts. I would encourage you to take a look at it. A lot of components. Neurology is very, very involved with these patients and doing the NIH stroke scale. Okay. One thing that you will do a lot, though, is the Glasgow Coma Scale, your GCS. You probably heard that term on TV many, many times. So what a Glasgow Coma Scale does is basically evaluate your ability to open your eyes, your availability, how well you speak or respond to things, and how well you move your body. So the lowest score you can possibly get is a 3, and the highest you can get is a 15. If you are alert, oriented, and a walkie-talkie like us right now, you are a 15. So with eye opening, we look at, do they open their eyes on their own for any number of reasons? Great, they would get a 4. If they only open their eyes when somebody's talking to them, to speech, they would get a 3. If they only open their eyes because of pain, they get a 2. And if they don't open their eyes at all, they'd get a 1. Verbally wise, we're looking again, alert and oriented. Side note, I never ask anybody who the president is, no matter who's president, because it always triggers some kind of tumultuous response. So I try to find something else that fits in there, but that's just me. Confused, maybe they don't know what's going on. They don't know what happened, but they know some things. Inappropriate, like their answers make no sense for the scenario. They're talking about ice skating instead of like where they are. Incomprehensible means you can't make out a sound. And then none would be they can't talk at all. Usually they're intubated. Motor response, you tell them to do something, they do it. Awesome. Pain response is a big thing. How do we elicit a pain response?
Maybe pinching their foot or their hand.
Mhm. Most commonly, we teach you guys to sternal rub. Take your knuckles right into their chest and go to kind of wake them up. Yeah, so do you know what happens when you go like this into somebody's chest and they're not actually like out? Maybe they're just sleeping or drunk.
I don't know. I heard it's really painful, but I had a patient and he got that done. And it was like so severe. Like he like lifted up his shirt and it was just like scabbed and bruised. But he didn't feel it. But I had a patient say it's severely painful when they do it.
Yeah, and if you're out of it, what do you think your response would be?
Like, yeah.
Yeah, so if you come at somebody and they're rubbing their chest, their instinct is going to be like, get off of me. So you have to be careful, protect your face, save your moneymaker. But I like to use the nail bed. I will dig into nails, or if I don't have nails, I'll take a pen and dig that into them to kind of generate this pain response. If they say ouch, or if they pull their hand away, and then we have things like the decorticate and the decerebral posturing. Do they flex in or do they go out with the pain? Because that has to do with what's going on with their brain, which will be a next semester thing, but that will determine what's going on. This is another thing where you don't necessarily need to have it memorized because it's in all of your documentation, but you need to know how to do it. Like my trauma room has it above the bed. So you can just look up real quick and be like, score of 12 or score of 5, whatever works. Over time, you tend to get really comfortable with it, but at any rate, this is something that we're going to do a lot. If they're a 3, again, they're probably intubated, high brain injury, not a lot is going on neurologically. They may be like vegetables at this point, like in a primitive vegetative state. There's a little rhyme, GCS of 8, we intubate. So a GCS of 8, they're at high risk for not being able to protect their airway. So they will tend to put a tube in there. So that could be because of drugs, because of trauma, other conditions, but it's a good guideline to go on. They're at high risk of not being able to. So other diagnostics, that non-contrast is performed first. If they determine what kind of stroke it is, then they can identify, okay, maybe we will do something with contrast or do an angiography or something along those lines. But we do non-contrast first because if they're bleeding into their brain, that'll pop up. And if we push contrast, it's going to make things icky. So hemorrhagic will show up on that non-contrast CT. Ischemic will not. But we can see edema, ischemia, death, self-necrosis. We can't see the actual clot for several days. So if they are worried about ischemic strokes, they're going to do further imaging that may result in contrast as well. But initially, non-contrast CT. All right. In terms of our planning, okay, our planning phase, our goal, our desired outcome is to prevent injury, a secondary injury. We need to keep them safe. So how do we do that? We need to monitor their vitals, especially really soon after a stroke. We need to be keeping their blood pressure elevated. Why would we want to keep their blood pressure elevated even if it caused their stroke? High blood pressure caused their stroke.
If you lower it super fast, they could go into some kind of shock.
Yep, and if we lower their blood pressure too much, we run the risk of it not perfusing well and getting enough blood to the brain. So it is not uncommon. It actually freaked me out the first time I saw it. I was like, oh my God, their blood pressure is like 170 over 100. And they're like, nope, that's okay. We want to keep it higher. So we keep it elevated to make sure that it stays perfused, and there'll be guidelines for you. Oxygenation is another big thing, especially if we're concerned about them not breathing on their own. Cardiac assessment, watching their level of consciousness. And then one of the big things that we see is helping them communicate. How are they communicating? Because not everybody can speak. Not all strokes are the same. Some people end up having very few deficits and others have a very hard time. So no matter what, you have to be able to identify what communication needs do they have. Are they able to make their needs known? What do I need to anticipate for them? Positioning wise, head of the bed elevated to 30 degrees in a midline position. So not all tilted and janky and off to the side. And if they're having issues, let's say with right-sided weakness and they can't hold it up, we want to elevate those extremities on pillows to help with support of them. Support is one of those interventions that are going to be huge, not just in helping with them with ADLs, but encouraging coughing, deep breathing, things that they may forget. Also, there's a lot of emotions involved with a stroke. You know, like I told the group yesterday or the day before, if all of a sudden you couldn't put on your shirt or go to the bathroom by yourself or wipe your own butt, how would you feel? You're completely dependent on other people. There can be a lot of rage and anger and depression. So we have to support the emotions that they're having because it's a lot. It's a complete lifestyle change of not only the patient, but the family as well. So those have to be part of the interventions that you're putting forward. Also, anytime there's a brain injury, whether it's a stroke or a trauma, we have to watch out for seizure precautions because the brain can just be like, nope, don't like that. And all of a sudden there's a seizure happening. Safety is huge. How do we prevent falls? It's the basics. Don't overthink that. Well lit, bed in lowest position, the right safety equipment, the right transfer equipment. If they're jumpers, get a bed alarm, you know, that sort of thing. We want to prevent them from hurting themselves, especially if they're impulsive or they are not aware of their deficits. You know, they might not know anymore that they can't use that whole right leg, but they're sure going to try. Well, they're at high risk for hurting themselves. So what are we going to do to prevent that from happening? These are the connections we need you guys to make. And then one of the big things is going to be feeding. So with feeding, CNAs can, or techs or whatever you call them, UPAs, I don't know, I will use the term CNA, they can absolutely feed people. But what they can't do is do the very first feeding or the very first feeding after a diet change. So if we change the texture of their food, that first feeding has to be done by a nurse. We want to assess to make sure that they are okay, that they don't aspirate, which is why we keep the head of the bed elevated too. CNAs can't suction. So if all of a sudden something happens with that first feeding, the nurse has to be there to help with that. So safe feeding. I know it sounds like, okay, we've been feeding people, we do this all the time, but dysphagia is a really common thing that happens after a stroke, difficulty swallowing. And dysphagia leads to aspiration. Aspiration can lead to pneumonia. Pneumonia can lead to death. So I know it sounds traumatic, but we want to prevent them from aspirating. So the proper feeding techniques are extremely important. Sit upright, ideally in a chair. We don't love when people are eating in bed because they can't sit completely upright. But if they can't get out of bed, highest position possible. A lot of patients that have strokes will have swallow precautions above their bed with instructions. You know, we have to get that chin to your chest when you're swallowing and reminding them. Suction at the ready. And then the big thing, a distraction-free environment. So let me ask you a question. What is dinner time like at your house? What happens?
I mean, my family usually has the TV on in the background.
So it's noisy and you hear things,
Yeah.
you're not paying attention necessarily. So that's what we mean by distraction-free environment. I don't know about you, but if you've ever watched like or been around feeding time, especially dinner, Wheel of Fortune or Family Feud or any of those games, like they can get pretty heated and they can cause distractions pretty easily. So that kind of stuff we want to try to minimize, reducing the noise, helping them if they need help with their utensils, that sort of thing. Because not only is things like TV or a phone distracting to a patient, it can be distracting to the person doing the feeding. We've all been guilty when we're in a patient's room and we kind of peek up and look at their TV and get sucked into the show that they're watching when you're spending too much time in there. So it's a safety for not only your patient, because they need to do what they need to do, you need to do what you need to do. With feedings too, dietary is heavily involved because we want to make sure that calories are there. They're going to expend more calories potentially, or if they're not moving as much, maybe not, but we want to get them adequate nutrition. And then speech is who dictates what kind of liquids and foods you're going to have. So they'll do the swallow study and that determines, oh yeah, you're going to be on thin liquids or you're on honey thick or nectar thick. So have any of you guys tried thickened liquids? Please tell me some.
As CNAs, we would get a new one on the floor and we would take them into the dietary room and fill up a cup of soda and then put as much thickening things as we could into it and then make them try it. And it's the worst. It is disgusting.
So what is the grossest thing you guys have had thickened?
The soda was pretty bad, but during my CNA class, I had to try water and like just the texture of it made me want to vomit.
You almost like want to chew it and you shouldn't want to chew water. So you can understand why people may not be so compliant with their thickened liquids. Coffee is one of those liquids that I don't think thickens well. It looks so gross, but somebody told me that like soda or Sprite, when you thicken it, it like traps bubbles. So like when it goes into your mouth, it kind of like pops almost. I don't know if that's true. I kind of want to.
It is true. And it's not very pleasant. It sounds
I'm
kind of
looking,
cool.
I want to try it.
I have tried it. It is not a good time. Would not recommend.
Okay. I'll probably end up doing it just because I'm that person. But yeah, that was interesting to me. And then the foods. Altered foods. You're pureed, you're mechanically altered, you're mechanical soft, and you're regular. So just because something is pureed does not mean that it tastes the same. There are certain foods that should just not be pureed, but they are. Meat is one of those things that just does not look appetizing, or eggs, like pureed eggs, just, I don't know. If there's anything else you guys have seen that is gross pureed, let me know. My favorite is when they try to make it into the shape of what they're actually eating. So it is more like food versus, mush, but consistency is very important. Alrighty, enough about that. Treatment. Our treatment for stroke patients, a lot of PT and OT. Anticoagulants, especially if it's an ischemic stroke, we want to prevent clots from getting bigger or breaking up. Aspirin, clopidogrel, thrombolytics, like we mentioned, and then it is not uncommon for patients after a stroke to be put on anti-epileptic drugs. So like phenytoin or gabapentin will help reduce that seizure threshold because they are at high risk for developing it. So it is not, again, doesn't mean they're going to be on it forever, but definitely, especially after that first, go around and the body's adjusting and healing. Also, just like anything else, stents can be placed, especially if we need to open up the vasculature, either in the brain or in the carotid. Either or can be done. I feel like it should come as no surprise that when caring for stroke patients, it is basically everybody and anybody. Any type of specialty is going to be involved in these patients. Neurology, because they deal with the brain. Neurosurgery, because they operate on the brain. Cardiology, speech, PT, OT, the lab, dietary, clergy, like I can't, there's a name for it and I can't think of what it is right now, like social services, case management. Everyone will be involved in this because so many systems are affected. Psych can get in with these patients as well. So it's extremely important that we collaborate and identify who takes care of what, which is usually the toughest issue. So we're not going to necessarily go to I was trying to think of a situation like if they are having issues with movement, that's going to be more of a PT thing than anything else. You know, identifying who takes care of what, which is usually like their system. And they might give you a little bit of the runaround. So document always. If you contact cardiology and they say, well, you need to talk to neuro, document exactly what they said. All right, and then our patient education. So this starts right away. And this isn't just talking to the patient, it's also including their family, because depending on the stroke and the severity of it, you might not be able to do any teaching to your patient. It may be just to the family. So we want to get them involved right away. There also will be a kind of like come to Jesus meeting, that there is a likelihood this patient will not get back to bed to normal. There's some type of residual effect in almost every stroke. So even if it's something small, like this hand just isn't as strong as the other one, or if they walk with a limp, or they're completely bedbound, that hope versus reality is a very difficult conversation to have. But it's difficult because we don't even begin to understand the limits of what the brain can do. We understand very little of it, even though we know so much. Additionally, education about resources and how things are going to be when you get home. So things that can get set up, care at home, what it will be like when that person comes home, because every stroke is different. But if there's major deficits, it can absolutely, well, no matter what, can create a caregiver role strain. So getting them access to respite care, where somebody comes in and takes over for just a day so you can go do something, or shower without being afraid of an injury happening. Is the house set up for people to be there safely? Rugs, no slip rugs, railings, lights. And getting people home, it can be very difficult for families to adjust because the patient isn't who they were beforehand. We see a lot of changes, those behavioral changes and physical changes as well. So, questions on strokes? Okay. Let's do some poll questions here. All right, so who is at the highest risk for a hemorrhagic stroke? And that is going to be B, uncontrolled hypertension, because the number one cause of a hemorrhagic stroke is uncontrolled hypertension. Your history of smoking, it's up there, but more so of an ischemic stroke versus a hemorrhagic. although it could, but most likely. Okay. Oh, I didn't launch it, or I'm just sitting here.
I was just gonna say, what the heck is everyone looking at?
I think this is the question though that yesterday gave us trouble. Like I launched it and then it went away right away, but people are answering, so that's there. One of the questions was being really tricky for 2 classes, and I'm like, I don't get it. I can't leave my face when I'm with you. All right, so what do you think the key to this question, answering this question is?
The nurse is planning care.
Okay.
New onset.
New onset, or is a not just new onset dysphagia, but what else? Something else is new.
Oh, the secondary.
A new dietary order.
Oh, yeah.
New dietary prescription. So what could possibly be included? So you're thinking, all right, what would I potentially do? Would I have suction equipment available? No doubt. Feed thickened liquids? That could potentially happen based on what the prescription is, the new prescription. Place food on the unaffected side of the mouth? Absolutely. And I don't think I stress this as much, but if they're having right-sided facial drooping, let's put the food on the left side because they're not using the right side as much, and that puts them at risk for choking. So definitely going to do that. Neck flexed. That's that chin to chest. We want it flexed. So yeah. And then assign an assistive personnel to feed them slowly. We would not do that because it's a new dietary prescription. So that first one we have to do. So we would do everything except for that last option. Once they get the go ahead from the nurse, go nuts, please feed them. Or if you really want to spend time with them, you do it. I like feeding time. Okay. I launched that one this time. I would just kind of watch to see where people are at with answering. If it doesn't move for like 5 seconds, I'm like, I think everybody answered. So everybody who answered got this correct. We will use the board of commonly used needs and phrases because it's helping them communicate. Talking on the phone is great for like emotional support and that sort of thing, but it doesn't help them communicate. And then finishing somebody's sentences is a good way to frustrate somebody. I think it's the nicest way that I can put it, because then they feel like they can't do it and it can end badly. And speaking louder isn't going to help them. But turning down your radio when you're looking for a house address definitely helps. All right, let's take it back to the beginning here. Aw, puppy. All right, so PAD, what would we expect? And that is going to be pallor on elevation and rubor when they are dependent. The scaling eczema with stasis dermatitis is more of a venous insufficiency issue. Cool, clammy, and cyanotic feet is not an expected finding unless it's like you're super elevated, you know, like, and even then we don't, it's not necessarily expected, whereas the pallor and the rubor are. Okay, so we have a potential abdominal aortic aneurysm rupture. What is the priority? And that is going to be administer fluids as prescribed and prepare for surgery. Pain medication could potentially be issue, but we're not going to continue to monitor. We need to act. And we can get an EKG, but we're not going to be giving TPA. If it ruptures, they're bleeding, TPA would just kill them faster. So A is your best option. And there we go. Alrighty, so Best response. These are always my favorite questions because sometimes you're just like, what? And that is going to be A. A single blood pressure does not confirm hypertension. That is the best. Oh, I didn't share. I'm sorry. The best response. Their age, that's not why we're reevaluating them. It's not because of their age. So that makes it not well. Few more for you guys. Alrighty, non-modifiable risk factor for hypertension, and that is going to be the family history, because unfortunately we can't do anything about our family. We can stop drinking, we can fix cholesterol. This is a tricky one. All right, so what does impending mean?
It is about to happen.
Right. So if it is no longer pulsating, if cessation means no more, if it's no longer pulsating, what does that mean?
That it's already ruptured.
It already ruptured. So this would not be the correct answer because it's talking about it hasn't happened yet. So this is something we would see after it ruptured. So before it would happen would be severe back pain or abdominal pain. That's a sign that it's an issue. We wouldn't see an increase in blood pressure. We're going to see a decrease. And we're not going to have the hemoptysis and crackles because that's more of a fluid overload type thing, or bleeding in the lungs or pulmonary edema, depends. So this, like I said, this was a tricky one because it's all about before. Okay. All right, so the leg is visibly swollen and reddened. What is the most appropriate action? And that is going to be B, inform them that they have a sign and symptom of a DVT. We don't want to mobilize the patient and dislodge any clots. And PRN, sub-Q heparin, doesn't exist. If we give subcutaneous heparin for prevention, it's usually twice a day, never as needed, because as needed sub-Q isn't going to do anything. And last one. All right. What is the primary assessment focus? ABCs. So cardiac and respiratory status. Everything else will be secondary, but always ABCs. If there is a priority question, ABCs are where we're going to go with this. Okay. Especially because there's a high risk of aspiration and not protecting airway. All right, what questions do you guys have? A lot of content we went over the last 4 weeks. Anything outstanding? Anything from last week you're still not sure on, you want me to touch on briefly? All right.
Are we going to, this is probably dumb. With the test, are we needing to identify like an EKG and identify like if it's a VTAC or VFib?
So that's not a dumb question. Originally that was the goal, but ATI doesn't like when we upload pictures. And the worst thing that could possibly happen to you is we put a question with the strip and the strip doesn't show up and then you panic and then I panic and it's just chaos ensues. So the focus for the exam truly should be, I have VTAC. What am I doing about it? Do I recognize the characteristics of it? Wide and bizarre, rapid ventricular rate. Is there a pulse? Is there not a pulse? So all those components you really put forth in that study guide matter. And I'm glad you brought up VTAC because always, always, always look to see if there's a pulse. Because if there's a pulse, we're going to do cardioversion. It's a planned synchronous timing shock to get them out of it. If there's not a pulse, we defibrillate and we start CPR. So that is a rhythm, right? It truly depends on if there's a pulse or not. So really understand what you would do for each of those rhythms. Do you understand what happens? If we describe to you frequent erratic P waves, more P waves in a QRS, you know, can you identify that it's AFib? Or if we talk about sawtooth pattern, a flutter, well, what do? Anticoagulate, you know, possible cardioversion if they're symptomatic, you know, that sort of thing. So really, how do we care for them? When you get into the hospital settings, you take specialized tele courses where you'll have to go into more of the measuring of the PR interval and things like that. I will say you do need to know heart blocks, especially for NCLEX. That pops up now on NCLEX. It didn't used to. So can you figure out what makes one first degree, what makes one second degree, type 1, second degree, type 2, and third degree? It's difficult, but it's all about the PR interval with heart blocks. And when we look at a rhythm strip, we don't look at one P and QRS. We have to look at everything in the strip. because with heart blocks, it could get longer and longer and longer, or it could be the same, or it could just be long throughout. So it's multiple components. I like Telly too. So if you have questions, reach out to me because it's like a game. It's figuring out like the puzzle. I don't know. Haley's shaking her head like no. But you know what? There's like such a satisfying feeling about being good at something and somebody being like, "Oh, you're really good at this. Can you take a look at it?" Or you can get an IV in a dead person. Can you try this person for me? Like it feels good to have that skill that people turn to you for. So
When you do your job good, you do other people's jobs as well.
so true. But it's also a tradable skill. Like I love starting IVs, but I hate putting in NG tubes. So that's something that I'd be like, hey, I'll go start that line in lab for you if you put this NG tube in there. Like it works, right? So it can make your job easier too. But at any rate, if questions come up, reach out to me. Like I said, I'm on PTO next week, but I'm still going to be available to do meetings and things like that if you don't mind, at a baseball field or, you know, hiding in my car, something like that. So I'm definitely there to do meetings for you guys. So
Are you going to Cooperstown? Is that what
no, we're going to Indianapolis.
Ooh.
Nothing exciting except in Indianapolis. All right. Well, that's all I have for you. Enjoy half an hour back of your time, and grades will be posted probably in an hour or so because I got to finish up a few things beforehand. So otherwise, have a good weekend.
Thank you.
Thank you.
Thank you.
Thank you.
I have a quick question for you.
Yeah.
So for this next exam, I think I told you a little bit earlier in the semester, but I work on Monday and Tuesday. If I'm like 5-10 minutes late to the exam, will that dock me? Like,
No, it would. The only time we really have an issue is like when it's an hour or
okay.
something, because we generally give like 15-20 minutes. I even give up to a half an hour just because like people are logging in. And I know that scanning thing sometimes can get real picky and jerkish. So we definitely, yeah, would allow that. And if we know ahead of time, I can let the person know who's proctoring, like, hey, this person is driving home. They'll be there in 15 minutes, and it's usually not an issue.
Okay, good deal. I was a little worried because I was looking at it and I was like, oh my gosh, I'm coming from clinical and or work because I have them on Monday and Tuesday. But okay, good to know. I feel a lot better.
Was it Monday or Tuesday?
I had both. So I have clinicals every Monday and then I work on Tuesdays. So
okay. So
yeah.
I think I'm doing the one on Tuesday, so that's definitely not an issue, but I can let the other instructor know on Monday. And half the time we're still letting people into the exam anyway, so don't worry
Okay,
about it.
awesome. Thank you so much.
You're welcome.